In lecture 2, we're going to start talking about the different tests that are on the chemical reagent strip that we use to perform the urinalysis. So in this lecture, we will get through ketones. We'll stop at the end of ketones and pick up in lecture 3 at blood. So along with the lungs, the kidneys are the major regulators of the acid-base content in the body. Normal random samples can be in the pH range of 4.5 to 8.0, with first morning samples usually being more acidic, so usually more around the 5 to 6 range, and a more alkaline result following meals, which is referred to as the alkaline tide. Because of the variation that can occur, there are not really any normal values assigned to urinary pH, and the result has to be considered along with other patient information such as acid-base content of the blood, the patient's renal function, presence of a UTI, their dietary intake, and the age of the specimen. Your book states that normal fresh urine cannot reach a pH of 9.0, that indicates an old bacterially contaminated sample, but I'll share with you something that has changed my view on that. So I had a sample urine specimen sent to the lab. This has been a few years ago, and it was from a patient on the obstetrics floor. The pH of the sample read 9.0. So, my first instinct was to think, okay, that specimen was collected a few hours ago. It's been sitting on the floor. It's been left out at room temperature, and it's an old specimen. So I called the floor and asked them to send me another sample. They brought me a fresh sample, ran the urine again, got the same result for the pH. So when I called the floor to tell them about this, discovered that the patient had been on acid reducers for acid reflux for years, and that was the only thing that we could come up with that would have caused that patient's urinary pH to be so high without it being an old specimen. So just so you know, fresh specimens can reach a pH of 9.0. Okay, clinical significance of the pH. It can be used in the determination of systemic acid-base disorders of metabolic or respiratory origin, and in the management of urinary conditions that require the urine to be maintained at a certain pH. So respiratory or metabolic acidosis or ketosis or alkalosis. So if a urinary pH does not conform to the patterns that would normally be seen in these disorders, then you could rule out that condition. Defects in renal tubular secretion and reabsorption of acids and bases. If the urine pH does not fit the pattern for one of those, then it could be due to a functional problem with the kidneys. Renal calculi or stones. Precipitation of inorganic chemicals dissolved in urine forms urinary crystals and renal calculi, but this precipitation depends on the pH of the urine. So only certain crystals form at certain pHs. So certain crystals can be ruled out if the pH is not right, and you can also control the formation of those crystals and calculi by controlling the pH of the urine. So urinary pH can be controlled by dietary regulation or medication. Treatment for UTIs. So maintaining an acidic urine can help to control UTIs caused by urea splitting organisms because they do not multiply as readily in an acidic medium. These organisms are also responsible for the highly alkaline pH found in specimens that have been allowed to sit unpreserved for extended periods. And then determination of unsatisfactory specimens. So the pH of the fresh urine should not exceed 8.5 in normal or abnormal conditions. Therefore, a pH above 8.5 is associated with an improperly preserved specimen. and should be recollected. And even with the experience that I had a few years ago that I just shared with you, if I had a sample that was 8.5 or higher, I would even knowing that it is possible, I would still ask for a recollection. Some different factors that can affect urinary pH. Diet, so a high meat and high protein diet can cause acidic urine. And then urine from vegetarians is more alkaline due to the formation of bicarbonate following digestion of many fruits and vegetables. Cranberry juice is an exception as it causes acid pH and is often used as a treatment for UTIs and bladder infections because it inhibits the colonization of certain urinary pathogens. And then medications prescribed for UTIs are metabolized to produce an acidic urine. Okay, the reagent strip reaction, or what's actually going on that reagent strip. So the two major brands of reagent test strips, which again were ChemStrip and Multisticks, they measure urine pH in 0.5 or 1 unit increments between a pH of 5 and 9. Both manufacturers use what is referred to as a double indicator system of methyl red and bromthiamyl blue. So methyl red produces a color change from red to yellow in the pH range 4 to 6, and bromthiamyl blue turns from green to blue in the range of 6 to 9. So you'll see that color progression from orange to yellow to green to a deep blue as it passes along that pH scale. There are no known interfering substances for pH, and the only source of error is runover between the reagent pads. On the Multisticks strips, the protein pad is very highly acidic and it is beside the pH pad. So if you have a runover, that acidic protein pad could affect the pH. And then also old specimens. Okay, the next test is protein. Of those routine chemical tests performed on urine, protein is the most indicative of renal disease. Proteinuria is often associated with early renal disease, which makes that urinary protein test an important part of any physical examination. Normal urine contains very little protein, so the normal range is considered is less than 10 milligrams per deciliter or 100 milligrams per deciliter in a 24-hour specimen. Mostly the proteins that you would find in urine are going to be low molecular weight serum proteins that have been filtered by the glomerulus and proteins produced in the genitourinary tract. Albumin is the major serum protein found in normal urine, and although it is found in high concentrations in the plasma, most of the filtered albumin is reabsorbed by the tubules, so urine concentrations are usually very low. Other proteins found in urine include small amounts of serum and tubular microglobulins, which is another low molecular weight protein. TAM horsefall protein, which is produced by the renal tubular cells, and then proteins from prostatic, seminal, and vaginal secretions. Okay, clinical significance. So it doesn't, if you're seeing protein in the urine, it doesn't always signify renal disease, but its presence does require additional testing to determine whether the protein represents a normal or pathologic condition. So clinical proteinuria is indicated at 30 milligrams per deciliter or greater. There are many reasons for proteinuria, and they can be grouped into three major categories. So you've got pre-renal, renal, and post-renal causes of proteinuria, and that's based on the origin of the protein. So pre-renal proteinuria is caused by conditions affecting the plasma prior to its reaching the kidney. So it's not actually indicative of renal disease. The condition is frequently transient and is caused by increased levels of low molecular weight plasma proteins associated with infection and inflammation. So those are referred to as acute phase reactants. The increased filtration of these proteins exceeds the normal reabsorptive capacity of the tubules, resulting in an overflow of the proteins into the urine. However, since reagent strips detect primarily albumin, pre-renal proteinuria is usually not going to be discovered in the routine urinalysis. Bence-Jones protein is excreted in persons with multiple myeloma. It's a low molecular weight protein that is excreted in the urine. The screening test for Bence-Jones proteins is not routinely performed. And unlike other proteins that coagulate and remain coagulated when exposed to heat, Bence-Jones proteins coagulate between 40 to 60 degrees Celsius, but then they're going to dissolve at 100 degrees Celsius. So a sample that is turbid at 40 to 60 and clear at 100 degrees Celsius can be suspected of containing Bence-Jones proteins. And there is confirmation testing for Bence-Jones proteins, and that's done by serum electrophoresis and immunoelectrophoresis. Okay, and then here's a list of pre-renal tubular disorders. So that includes intravascular hemolysis, muscle injury, which would indicate myoglobin, acute phase reactants, and multiple myeloma. So next we're going to talk about renal proteinuria, which proteinuria associated with true renal disease is the result of either glomerular or tubular damage. So we're going to talk about the differences. So with glomerular proteinuria, there is damage to the glomerular membrane that impairs the selective filtration so that increased amounts of serum proteins and eventually red cells and white cells are going to be able to pass through the membrane and are secreted in the urine, and abnormal proteins deposit on the membrane. So this is mainly seen in autoimmune disorders such as lupus and streptococcal glomerulonephritis. You've got increased pressure from the blood entering the glomerulus that may override the selective filtration of the glomerulus that can cause increased albumin to enter the filtrate. This can be seen in conditions like hypertension, strenuous exercise, dehydration, and preeclampsia during pregnancy. And then benign proteinuria is most often transient, can be caused by conditions like exposure to cold, high fever, exercise, and dehydration, which we've already mentioned those. Orthostatic proteinuria is one type of persistent benign proteinuria. It occurs frequently in young adults, and it occurs following periods spent in a vertical position and then disappears when a horizontal position is assumed. So it's thought to be due to increased pressure on the renal vein when the person is in the vertical position. Testing for this condition is done by the patient emptying their bladder before going to bed, and then the specimen should be collected immediately when they get up from sleep, and another specimen should be collected a few hours later. So both specimens are tested for protein, and the first morning specimen should be negative for protein, while the later specimen would have protein present. Microalbuminuria, this is seen commonly in people with type 1 and type 2 diabetes mellitus. Diabetic nephropathy leads to reduced glomerular filtration and eventually leads to renal failure. So microalbuminuria is one of the first predictors of renal complications in diabetics. It can also be associated with increased risk of cardiovascular disease. Okay, and then tubular proteinuria. Increased albumin is also seen in disorders that affect tubular reabsorption because the normally filtered albumin can no longer be reabsorbed. Causes include exposure to toxic substances and/or heavy metals, severe viral infections, and Fanconi syndrome, which is a group of disorders marked by renal tubular dysfunctions associated with some inherited and some acquired conditions associated with drugs or heavy metals. And the amount of protein that can be seen in glomerular proteinuria is up to 4 grams per day. In tubular proteinuria, the amount seen would be much less. Okay, and here's a list of the glomerular disorders. So you've got immune complex disorders, amyloidosis, toxic agents, diabetic nephropathy, can be due to strenuous exercise or dehydration, hypertension, which is high blood pressure, preeclampsia, which would be seen in pregnancy, orthostatic or postrenal proteinuria. Okay, and then finally, postrenal proteinuria. So the protein can be added to the urine specimen as it passes through the structure of the lower urinary tract. So that would include the ureters, bladder, urethra, prostate, and vagina. Bacterial and fungal infections produce exudates that contain protein. The presence of blood as the result of injury or menstrual contamination contributes protein, as does the presence of prostatic fluid and large amounts of spermatozoa. So any of those can cause protein to be in the urine. Okay, the reagent strip reaction is called the protein error of indicators. So the strips will contain either tetrabromophenols, which is in the multi-sticks, or another big long word for the reagent that I'll let you guys look at. Excuse me, right here, which is the reagent in the chem strip, and an acid buffer to maintain the pH at a constant level. So at a pH of 3.0, the indicators are yellow in the absence of protein, and as the protein increases, the color progresses through various shades of green and finally to blue, and each of the color changes corresponds to a reportable value. The test strips, I mentioned previously, the test strips are most sensitive to albumin because the albumin is capable of accepting more hydrogen ions than other proteins. So the very acidic reagent pad loses hydrogen ions the higher the protein concentration is in the urine, and the protein accepts the hydrogen ions that are in the reagent pad, which removes them from the reagent pad, which causes the color change. And there's just a visual representation of what's happening during those reactions. Okay, reaction interference. For protein, the major source of error with reagent strips occurs when the specimen is highly alkaline, and it can override the acid buffer in the pad, so that could cause a false positive. Leaving the reagent strip in the urine too long can cause a false positive. Other false positive readings can occur with highly pigmented urine or when the container is contaminated with quaternary ammonium compounds, detergents or antiseptics, and also specimens with a very high specific gravity. False negatives can occur when there are proteins present other than albumin. Okay, the sulfosalicylic acid or SSA, this is one of those confirmation tests I mentioned in lecture 1. So this is a confirmation test that is performed on positive reagent strip reactions for protein. A cold precipitation test that reacts equally with all forms of protein, so it can detect Bench-Jones, globulin, albumin, etc. You've got various concentrations of and amounts of SSA that can be used to precipitate proteins. It has to be performed on a centrifuged specimen, and this is really not a commonly used test anymore, and that's really just due to instrumentation. So a lot of labs don't perform this test anymore. But again, I think I mentioned there is a Moodle video on it if you want to take a look at it. Microalbuminuria strips. So this is new testing. So previously I mentioned that they have reagent strips that test for multi parameters, and then some that are just single tests. So the microalbuminuria strips were developed to identify patients at risk for diabetic nephropathy or cardiovascular disease. It should be done on a first morning specimen, and then there are several different strips in use now from different manufacturers. All of them use different methodologies. Okay, the next test that we're going to talk about is glucose This is the most frequently performed chemical test on urine because of its value in the detection and monitoring of diabetes mellitus. It also helps patients to monitor themselves at home and can detect problems prior to development of serious complications. So clinical significance: under normal circumstances, almost all of the glucose in the blood should be reabsorbed by the kidneys based on the body's need to maintain an adequate level of glucose, and so urine should only contain minute amounts. Glucose is seen in the urine when the renal threshold for glucose, which is 160 to 180 milligrams per deciliter, when that threshold is surpassed. So that could be like in cases of hyperglycemia, which is when blood glucose levels become elevated, which occurs in diabetes mellitus. But glycosuria can also be seen following a meal that has a high glucose content. So it's best to obtain a specimen that's collected under controlled circumstances. Gestational diabetes. So this is hyperglycemia that's seen during pregnancy that will disappear after delivery. Hormones are secreted by the placenta that block the action of insulin, which results in insulin resistance and hyperglycemia. This is important to the welfare of the baby because glucose can cross the placenta, but insulin cannot. So the baby can develop high glucose levels, and its pancreas produces more insulin, and this excess glucose that is presented to the baby is stored as fat, so it can result in a very large baby, which puts the baby at risk for obesity and later type 2 diabetes. Women who have gestational diabetes are also at greater risk for developing type 2 diabetes later in life. Okay, non-diabetic hyperglycemia. This is caused by hormonal disorders. So it can be from pancreatitis, pancreatic cancer, acromegaly, which is a tumor of the nervous system that produces excess hormones and causes high blood pressure, headaches, and nausea. Cushing's syndrome, which is a condition caused by prolonged exposure to cortisol. So patients will show a high blood pressure. They'll have, a lot of times will have a round red face, weak muscles. Hyperthyroidism, pheochromocytoma, which is another type of tumor in the nervous system associated with the hormones glucagon, epinephrine, cortisol, thyroxine, and growth hormone. So these hormones are increased in these disorders, and they work in opposition to insulin. So this leads to hyperglycemia and glycosuria. Normally, insulin converts glucose to glycogen, which is the storage form of glucose the body releases when it's needed. And then for storage, which is glycogenesis. But these hormones cause the breakdown of glycogen back to glucose, which is referred to as glycogenolysis, which results in increased levels of circulating glucose. So epinephrine inhibits insulin and is seen in cases of severe stress, which explains the glycosuria seen in conjunction with cerebrovascular trauma and myocardial infarction. Okay, renal glycosuria, which is also referred to as glucosuria, is glycosuria in the absence of hyperglycemia. So the patient would have an increased urine glucose but a normal plasma glucose. This is a renal tubular disorder seen in end-stage renal disease and Fanconi syndrome, and sometimes during pregnancy. Okay, the reagent strip reactions. This is called a glucose oxidase reaction that is specific for glucose, in which the test pads are impregnated with a mixture of glucose oxidase and peroxidase. So those are your reagents. There's a chromogen and a buffer to produce what's referred to as a double sequential enzyme reaction. So in the first step of the reaction, glucose oxidase catalyzes a reaction between glucose and room air to produce gluconic acid and peroxide. In the second step of the reaction, peroxidase catalyzes the reaction between peroxide and the chromogen to form an oxidized colored compound that is produced in direct proportion to the concentration of glucose present in the sample. And again, there's just your visual representation of what's happening during that reaction. Okay, and some reaction interferences. False positives can occur in the presence of peroxide or other strong oxidizing detergents. False negative results can occur when there are interferences with the enzymatic reactions or something that prevents oxidation of the chromogen, such as with ascorbic acid, which is a strong reducing agent. Does anybody know what ascorbic acid is? That is vitamin C. High levels of ketones, which are a byproduct of fat metabolism, can also cause false negatives, though this is unusual because ketones are usually accompanied by glycosuria, so that's rarely a problem. High specific gravity and low temperature may decrease the sensitivity of the test, but the greatest source of false negative reactions is from allowing the specimen to sit unpreserved at room temperature for extended periods, which allows bacteria to utilize the glucose. Okay, the copper reduction test, or the CliniTest. So again, this is one of the confirmatory or backup tests that were mentioned in lecture 1. This is one of the earliest chemical tests performed on urine used to detect glucose. So the test relies on the ability of glucose and other substances such as galactose, lactose, fructose, maltose, and pentose to reduce copper sulfate to cuprous oxide in the presence of alkali and heat. When the reaction takes place, a color change progressing from blue through green to yellow to orange or red will be seen. The Benedict solution was developed in 1908 and is still used in the CliniTest tablet today. The CliniTest procedure, and again, there's a video in Moodle. Please watch it. It'll help this procedure make sense. But this is a tablet. The tablet contains copper sulfate, sodium carbonate, sodium citrate, and sodium hydroxide. So you have to use a glass tube where you add 5 drops of urine and 10 drops of water. The tablet is then added to the water and urine solution. Heat is produced by the hydrolysis of sodium hydroxide and its reaction with sodium citrate. Carbon dioxide is released from the sodium carbonate to prevent room air from interfering with the reduction reaction. So you'll actually see like a bubbling or kind of a boiling reaction that's going on in the tube. When that tube is finished bubbling, you shake the tube gently and observe the color change and compare that to the manufacturer's color chart to determine the approximate amount of reducing substance that is present. And you have to watch the reaction closely from start to finish to make sure that what's referred to as pass-through does not occur. This happens when there are large amounts of glucose in the sample and the colors pass through to orange-red, but then passes back to blue. So it could be reported as a negative if close attention is not paid to that reaction. When pass-through occurs, the procedure has to be modified to a 2-drop method. The sensitivity of this test is higher than that of the reagent strip reaction, and so it will detect smaller amounts of reducing substances, but it's not specific for glucose. And there's just a picture of the box, and here's the tube that the reaction has taken place in, the color chart, the manufacturer's color chart that you have to compare that final result to. Okay, some clinical significance of and the reaction interferences for the copper reduction. So this test is not specific for glucose, but it tests for many reducing substances. Reducing substances are elements or compounds that lose electrons in a chemical reaction, but presence of these are indicative of metabolism disorders such as galactose, lactose, fructose, and pentose. So galactose is the most important of those because its presence in the urine of newborns represents what's known as an inborn error of metabolism, in which the lack of a specific enzyme prevents the breakdown of ingested galactose. It results in failure to thrive and other complications, and eventually death if it's not caught and treated in time. All states now screen for galactosemia as part of their newborn screening programs because early detection followed by dietary restrictions can control the condition. Many labs also routinely screen all urines from patients ages birth to 2 years for the presence of reducing substances. So if the reagent strip result for glucose is negative, but the clinitest is positive, this could indicate one of those inborn errors of metabolism. It's considered a critical or an alert value, so it has to be called to the nurse or to the doctor. And here is just a glucose oxidase and clinitest reaction correlations. And then a list of the clinical significance of urine glucose, so different conditions that it can be associated with. And again, just broken down by renal associated versus other. Okay, the last reagent strip parameter that we're going to talk about in this lecture is ketones. We'll pick up in lecture 3 at blood. The term ketones represents 3 intermediate products of fat metabolism. So that includes acetone, acetoacetic acid, and beta-hydroxybutyric acid. Normally, ketones are not present in measurable amounts in urine, but when the available carbohydrate stores are depleted, fat has to be metabolized for energy. So this is the point at which ketones may be seen in urine. Okay, clinical significance. Clinical reasons for increased fat metabolism include the inability to metabolize carbohydrates, such as in diabetes mellitus. It could be increased loss of carbohydrates from vomiting or strenuous exercise, inadequate intake of carbohydrates due to starvation and malabsorption, or diets that restrict carbohydrates. Testing for ketonuria is valuable in the management and monitoring of insulin dependent, which is type 1 diabetes mellitus, because ketonuria shows a deficiency in insulin and indicates the need to regulate dosage. Increased accumulation of ketones in the blood can lead to electrolyte imbalance, dehydration, and can lead to acidosis and diabetic coma if it's not corrected. Okay, the reagent strip reaction. So the reagent strips mainly measure acetoacetic acid. The reagent strip tests use the sodium nitroprusside reaction to measure ketones. So in this reaction, acetoacetic acid is in an alkaline medium, reacts with the reagent sodium nitroprusside to produce a purple color. The test does not measure beta-hydroxybutyric acid at all and is only slightly sensitive to acetone when glycine is present, so that would be in the chem strips. However, because these compounds are derived from acetoacetic acid, their presence can be assumed so that it would not be necessary to perform tests for the individual compounds. Okay, the acid test is another one of those confirmatory or backup tests that we mentioned in lecture 1. So this is a confirmatory test used mainly when urine ketone results are questionable, but was mainly used on serum and body fluids in cases of severe ketosis to determine the extent. So to determine the extent, you would have to do a serial dilution and perform the test on serum. This is a tablet test. The tablet contains sodium nitroprusside, glycine, disodium phosphate, lactose, which the addition of the lactose gives a better color differentiation, but positive is still a purple reaction. Okay, for the acid test procedure, The tablet is placed on a white gauze or paper. 1 drop of urine is placed on the tablet, and then you read the result after 2 minutes. Urine should be completely absorbed into the tablet within 30 seconds. The resulting color should be compared to the color chart supplied by the manufacturer, and the undiluted sample test should be reported positive or negative. If the undiluted sample is positive, then this is when you would do that serial dilution and report it as positive or negative for each of the dilutions. And here's an example of that test, and we should be performing one of these in class, and I think there is also a video for this one in Moodle. And then some of your reaction interferences, certain dyes and medications or red colored urines, medications containing sulfhydryl groups, reactions with interfering substances will fade after standing. So while color development from acetoacetic acid increases in intensity, but it could result in false positive reactions if the strips are allowed to sit for too long before being read. And then false negative results can be due to the volatilization of acetone and the breakdown of acetoacetic acid by bacteria, which could happen with improperly preserved specimens. Okay, that is where we're going to end off lecture 2, and then we'll pick up with blood in lecture 3.